Do you think pornography is harmful?
Pornography can be utilized for the benefit of the individual or for the couple.
Doing masturbation in an idiosyncratic fashion, like death grip, certain positions, are these truly harmful?
I think if you grab too tightly, my semen is more yellow, my semen is more watery. Semen is a very interesting product. And I think from a color standpoint, anything other than red or black, or brown, as the blood changes, I just wouldn't be concerned. You have an orgasm, male or female, when you're in the zone, because adrenaline is an anti-erection chemical.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik, urologist and pelvic surgeon. Today I interviewed Dr. John Mulhall. He is a world leader in sexual medicine and the director of sexual and reproductive medicine at Memorial Sloan Kettering Cancer Center. Today we had a wonderful discussion. We talked about a lot of the popular topics that people always want to know about, like semen retention, pornography, masturbation, and ejaculation. What should ejaculate look like? How much ejaculate volume should there be? And what is premature versus delayed ejaculation, and what can you do about it? We also talked about erectile dysfunction. Specifically, we talked about the medications for erectile dysfunction and do they have a role in prevention? We also talked about the penis cocktail of medications, so make sure you listen to hear about that one. And we covered injectable therapy for erectile dysfunction. Lastly, we covered what happens after prostate cancer to erections. What is penile rehabilitation and what does that involve? And what can you expect in terms of recovery for erections if you've undergone prostate cancer treatment? I know you guys are going to love this conversation as much as I did.
Dr. Mulhall, thank you so much for being here.
My pleasure, Rena.
I'm really excited to have you here. You are one of the world leaders in sexual health and a giant in our field, and it is truly an honor.
It's my pleasure to be here.
So I want to talk about some sort of hot topics that people love to ask questions about. In terms of semen retention, people tend to believe there are quite significant benefits in terms of psychological benefits and as well as benefits with testosterone. So what do you tell patients when they want to pursue or participate in something like No Nut November, say?
You know me very well. I'm very data-driven. And so the reality is that there's just not great scientific data behind it. We've got lots of anecdotal data. And of course, we're taught in medical school that anecdotes isn't statistics. So I think that this is a very personal thing. I'm in Manhattan, so we've got lots of people of all kinds of genders, orientations, and kind of sexual interests. So we've got plenty of people who come in who talk to us about what semen retention has done for their lives. And I think if it helps them, then they should do that.
Yeah.
I think there are other people, of course, this whole blue ball syndrome where they are distressed and they've had negative experiences exploring semen retention as a concept. So I think it's just a personal thing, but I say there is no good scientific data that it's going to improve your virility, it's going to improve your erectile function, it's going to change your orgasmic intensity, as some people believe it does. From a testosterone standpoint, it's an interesting question. So I was listening to another expert on the podcast talking about there just isn't good data about that, right? In the testosterone space. So I don't know the answer to it. And without having, scientific literature on testosterone levels in men who do this, because that would be very complicated study to do, I just don't know what to tell patients.
Yeah.
To be honest.
Yeah. And I think honestly, I say the same thing is if it gives you benefit by all means. But what I worry about is that whole blue ball syndrome where people are struggling, suffering, miserable for a month or however long they're trying to do this for, and then develop pelvic floor dysfunction.
Yeah, the whole blue balls thing is very interesting. In the sense, does it really exist or not? Right? There's, I don't know how often you have female sexual medicine experts on your podcast. But if you speak to them, they'll talk about blue ball syndrome being used as a means of coercion of partners into having sexual activity, which is a very interesting concept that I haven't really thought much about previously in my 28 years in my career, but I'm becoming more kind of aware of that concept. I think there are men who have, in quotations, blue ball syndrome from absence of ejaculation for a protracted period of time. That is more mentally or even pelvic floor
Correct.
related
Yes.
than it has anything to do with testicular or epididymal hypertension,
Yeah.
which are some of the proposed concepts.
When I first heard about epidural hypertension, I was like, does this even make sense? That like one very small part of an organ would get hypertension and create so much pain? Because we get that in a multitude of organs and we don't see it in other organs.
Yeah. It's never been done, but we're fascinating to do. Take men who run a personality inventory, anxiety, depression scores on men who are prone to lupus and see, are they more anxious at baseline? Are these the high adrenaline guys who get chronic pelvic pain syndrome, pelvic floor dysfunction as well? So, listen, the first two questions on this podcast are, I'm sorry to say, just unanswerable based on data.
Yeah.
So, and then of course, very well, that was evidence-based medicine.
Mm-hmm.
And then there's the other EBM, which is eminence-based medicine, where somebody famous stands up and says something that's, attractive and interesting. And, Dr. X says it, it must be true. And I think for non-medical people listening to your podcast, there is a distinct difference between evidence and anecdote.
And the other thing to really be thoughtful about is you can find evidence to support almost anything.
Yeah.
Because there are small studies, there are animal-based studies, there are, 8 men getting some treatment. And that is not enough
100%.
to be rigorous, scientifically studied evidence.
That's really, really important information. I just came from a session at the American Neurological Association meeting where, there's a novel therapy for Peyronie's disease. And then all of a sudden you look at the poster and it's 5 men, right? So you can't extrapolate from that. This is a kind of exploratory study, et cetera, et cetera. But you're right that if you can look for you can find almost any paper on any subject in our field that will support X or Y.
Yeah, there is a paper on semen retention. There's one paper. I've talked about it many times on my channel. Feel free to check out those videos. But yeah, there's one paper that shows testosterone increases with semen retention. Is that now rigorous data? No. Yeah.
It might be, maybe I could just make a comment on testosterone measurement, right? So for patients, right? So generally speaking, there's a circadian rhythm, okay? And testosterone levels are highest within the first couple of hours of actually waking. We generally insist on our patients having it done before 10 o'clock in the morning, okay? There are some authorities who disagree with that. Certainly that circadian rhythm becomes blunted as men age. So men who are over 60, is that as important? Probably not. But we just use the routine of checking it early in the morning. Then there are different assays, right? There are different tests that can be used, some of which have very high coefficients of variability. So, for example, an immunoassay for total testosterone measurement, that can have a 15 to 30% coefficient of variability, particularly at very low and at very high levels, okay? So we use a thing called LCMS for total, and we use equilibrium dialysis for free. If you have the option to say to your doctor, can I get the most accurate testosterone test done? Then I would strongly encourage you to do that. If you're going to have testosterone measured, do it at the right time, and let's get the best test possible.
Well, and there's so much individual variability from day to day.
Yeah, that coefficient of variability will be very narrowed by using the most accurate assay, which you're absolutely right. And this is why we insist on getting at least 2 testosterone levels done, because of the intra-individual variability, for sure.
Exactly. What about pornography? Do you think pornography is harmful?
Yeah, so this is, another hot topic in our field at the moment. And I think, people bring into this discussion their own personal beliefs. They project onto patients. They bring cultural and religious beliefs into this whole thing. And I think that pornography can be utilized for the benefit of the individual or for the couple. The problem becomes when you take certain personality types, obsessive compulsive people, and those more prone to addiction, and they become entirely reliant on that, right? So pornography is essentially fantasy for most people, and particularly young people who are being introduced to their own sexuality early on now with free pornography online, and they get exposed to things that they don't quite know how that relates in a bedroom setting. And their expectation in the bedroom is set at a very abnormal or high level, and that expectation is not met, right? However, I have many couples who integrate pornography into their own love life to enhance their sexual arousal, their sexual experience with their partners. So I think when judiciously used, when not being completely relied upon being the only means of sexual arousal, I think it can be a very positive tool. And there is good medical literature on this. So there are plenty of people who publish in our journal, the Journal of Sexual Medicine, who publish elegant research on pornography and its potential benefits. But it is the obsessive compulsive addictive type personality who gets involved in this. And this is the only thing they rely on. That is a negative.
Yeah, absolutely. And, we had a psychiatrist on who said that, she's done some work on pornography addiction, and it's that they actually find that they're not using the pornography. It becomes not all about the sexual fantasy, but also just because it allows them to avoid negative thoughts. It becomes something that drowns out negative thoughts. So that was really interesting.
Yeah. The other potential benefit, but even for younger people in pornography, male and female, all genders, is exploration of one's own sexuality. And that's a big, big thing for me in the sense that I think there's so much repression and shame and guilt surrounding the concept of sex, culturally, religiously, parental edict. And I think that pornography, if used correctly, can help the individual explore their own sexuality and become the person they really are.
Yeah.
Right? So I think there are benefits for sure.
As long as they're not changing their expectations because of what they see.
Correct.
Yeah. Because I think I always caution people that it's a produced product. It's not real life.
Right.
And then that leads to the question about doing masturbation in an idiosyncratic fashion, like death grip, certain positions. Are these truly harmful? And what do you see?
Yeah. So, there is no right or wrong way to masturbate. And I think that just like pornography, masturbation early on in life is a good strategy for exploring your own sexual pleasure and trying to identify what it is that makes you feel good. I think that will only help you in communicating with your partner about what you want to do in a partner-based setting. I think idiosyncratic masturbation is a very interesting concept. And, that's kudos to Michael Perlman, who kind of introduced the concept many, many years ago. And the general idea, let's just talk about men, for example. The general idea is that a man grasps his penis and is trying to replicate what a mouth, a vagina, or an anus does, right? And so when that grip or the technique is such that it cannot be replicated by a partner, those men are at risk for delayed orgasm, anorgasmia, reduced sexual pleasure. And so the classic example are men, for example, who lie on bed, face down, or on a pillow, and are dry humping the sheets or whatever. Their partner-based relations, oral sex, vaginal, anal intercourse, will never replicate that. So they're setting themselves up for failure. Okay. There's a lot of talk at the moment about masturbation coaches. There's a group of mental health professionals and practitioners who are self-identifying as masturbation coaches. And I have patients come in and say, should I employ a masturbation coach? And I think I would do that if and only after you're unable to achieve sexual pleasure yourself through learning through pornography or reading material. And so I think that masturbation, there's no right or wrong way. I think if you grab too tightly, consistently, then you're going to end up being in a situation where most vaginas or anuses are not going to replicate that. I think if you're into a 2-hour session where you're edging consecutively, I think that's a problem. I think you're going to hyperstimulate and overstimulate your penis and reduce the likelihood of achieving orgasm. And of course, most sexual encounters in the United States of America don't last 2 hours.
Or in the world, probably.
Right. Yes, of course. So listen, I think that there is, while we say there's no right or wrong way to do it, I think when you start veering off, replicating what a partner can do for you, then you start raising some potential issues in the bedroom scenario.
Yeah. And similarly with women, if you're using the same vibratory tools every single time, that cannot be replicated by a partner with their mouth or their fingers, and so that's going to, again, I think you habituate to that sensation, and that's sort of the challenge.
Yeah.
In terms of ejaculation, I think you're on the guidelines for ejaculatory dysfunction. Let's first just start off with what's normal in terms of ejaculation, in terms of the amount, the color, the texture, because people have a lot of questions about that.
Yeah. So we get a lot of penocentric, genitocentric, semenocentric patients in our practice. I'm in Manhattan. A lot of very high adrenaline patients coming in, very distressed about their sexual problems. So from a volume standpoint, it's 1.5 to 5 cc's would be considered normal. The longer the period of absence, the more semen you're going to produce. But this idea that, you're producing a liter of semen is incorrect. It's basically a teaspoon, okay, for the most part. From a color standpoint, the color is going to vary based on the abstinence period. But there are two colors that you need to be concerned about. One would be red, so blood, hematospermia, which 98% of the time is the result of a benign issue, but there are cancer issues that are associated with that. That is surprisingly more common than many humans believe, but we see a lot of that in our practice. And then the other would be black semen. And I work at a cancer center. And we've had, would you believe, over the last several years, 2 cases of melanospermia, right? Where men actually have a seminal vesicle melanoma. Okay, so as rare as that would be, black is a bad thing. If you have bright red blood in your semen, don't freak out. Okay, it's nearly always nothing to be overly concerned about. And that, just like a bruise, that blood will go from bright red, it will change color over the ensuing period of time. If a man in our practice has a persistent hematospermia over 10 ejaculates, and it's not over the period of time, that 10 ejaculates might be 10 days or it might be a month, but then we'll kind of opt to get an MRI. We then get a digital rectal exam to check their prostate. We do some blood work, but the MRI would be for us the kind of go-to imaging. There are some urologists who use a transrectal ultrasound, but I think the MRI in its 3T format is probably more accurate. Certainly if you want to look at seminal vesicle structure and stones in the prostate, stones in seminal vesicles and blood. So from a color, and would you believe odor and even taste standpoint, we get these questions in our practices, as you know. I really try and encourage people to stop paying a lot of attention to that. Okay. Taste, for example, will change with ingestion of foods, the whole asparagus versus citrus foods concept, right? And I think from a color standpoint, anything other than red or black, or brown, as the blood changes, I just wouldn't be concerned. My semen is more yellow. My semen is more watery. Semen is a very interesting product. People think it's mostly sperm, when it's 5% sperm, right?
Right.
And it's 20% prostatic fluid, and it's 85% or 75% seminal vesicle fluid. And depending on how much of the semen is from the seminal vesicle versus the prostate, its consistency and its color is going to change.
When was the last time a doctor spent an hour with you and truly focused on your goals? And when was the last time you left feeling like you really understood what was going on with your body and had a clear plan of what was going to happen next? At my practice, Rena Malik MD, I aim to do just that. I specialize in sexual dysfunction, bladder health, hormone health, and pelvic pain for all people. And I want to revolutionize how we take care of patients. I want to really get to know each and every one of you. That's why at my practice, when you come to see me, I'm 100% present with you for an entire hour. And after you leave, if you forgot to ask me something or need clarification on something we talked about, don't worry. I'll respond to your issues and questions quickly through our secure messaging portal without any additional costs. Just go to www.renamalikmd.com/appointments and schedule your visit today. We see patients in Irvine and Beverly Hills, California, and virtually for patients from California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. If you aren't located in these states, consider making an educational visit where we can talk about your conditions generally, but I can't diagnose or treat you. I can't wait to see you.
And just for the providers listening, because I'm sure a lot of primary care doctors, even urologists, get the question about, the blood in the semen. Yeah. If they're ordering an MRI, if it persists after 10 ejaculations, is it a 3T MRI with or without contrast?
We do both with and without. Okay. And so the other thing about MRIs, pelvic MRIs, and particularly, prostate type MRIs, is I had an MRI done. The reader of the MRI is just as important.
Absolutely.
So it's not just the technology, it's make sure that is read by somebody who specializes in, probably the best group will be the prostate MRI guys. Yeah. And of course, at Memorial Sloan Kettering, some of the world authorities there, right? So I had a single body MRI radiologist read all of my MRIs for penis and for a hematospermia.
Great. So I would say if you don't know, find out where the prostate cancer doctors are sending their patients for MRIs, and that's probably a good bet. Let's talk about ejaculatory dysfunction.
Yep.
So premature ejaculation is one of the biggest insecurities of men, meaning not lasting long enough, having an ejaculation before you'd like to. What, in terms of premature ejaculation, do you offer to men? Most of the treatments we have are sort of off-label for these things.
Yeah. Let's talk about the definition
Yes.
of premature ejaculation. So there is lifelong premature ejaculation, which is ever since I started ejaculating, I'm rapid. The International Society for Sexual Medicine would define that as ejaculation within about a minute,
Mhm.
most of the time, that causes personal distress and or relationship discord. So there are a number of components of it, right?
Yep.
So the classic example is a man who comes in who says, I was married for 25 years. I always came within a minute. It was never a problem because my wife came even sooner,
Mhm.
right? And then he's got a new relationship. And his new partner has an orgasm, his female partner has an orgasm in 7 minutes. Now he's got premature ejaculation,
Mhm.
right? So it's not just about the time, okay? The other group are the men who have acquired premature ejaculation. And there are men who, for all their life, they've been fine. And a year ago, all of a sudden, they started coming more rapidly.
Mhm.
Okay. And that's usually within about 3 minutes, will be the general definition. Again, with relationship disorder, personal bother, et cetera, et cetera. And that is predominantly an adrenaline mediated phenomenon. There is some literature suggesting that hyperthyroidism is associated, or chronic pelvic pain disorder, type 2, PB, prostatitis, is associated. But really, the vast majority of men in my practice who have secondary PE, acquired PE, have acquired PE secondary to erectile dysfunction.
Mhm.
So because they've got problems with their erections, because they got loss of sustaining, they're working harder and quicker to try finish off before they lose their erection. And that just hyperstimulation, and they just get themselves into rapid ejaculation. From a treatment standpoint, there is no, in the United States of America, FDA-approved drug. There are 3 approaches, as you well know. There are psychological, mental health approaches that are grouped under the umbrella term sensate focus, things like stop-start, squeeze technique, etc. They have very poor long-term consistency of benefit. So if you look at the literature, you're probably looking at a 25% success rate at 2 years after you've started doing that. So you have to kind of consistently do that if you're a lifelong PE. That's typically coordinated by mental health professionals, specialists in our space, in kind of the psychology too. That requires a patient and a partner to commit to doing this.
Yes,
So
the partner needs to be on board.
100%. So now you have a 35-year-old couple with 3 young kids at home who have sex once every 2 weeks, and now they have to devote that sexual encounter to exercises, which is actually hard to comply with.
Mhm.
The second group of treatments are transdermal agents, so sprays, gels, creams, which have local anesthetics in there. The ones that are over the counter don't have fantastic permeators. There are more non-over-the-counter based agents that have special permeators. So, for example, the absorption pharmaceuticals agent Promescent has, if you've ever smelled that, it smells like thine, because there's thymol in it, and thymol is a permeator which drives the local anesthetic across the skin. It's a balance between making somebody insensate and not able to feel anything,
Mhm.
and making them just insensate enough where it's going to dull the sensation and prolong ejaculation time. They probably, in my practice, and there's really not great literature on this, right? Really probably 1 in 2 chance to make a significant difference to these patients. The mainstay of treatment, and again, not FDA approved, it's off-label, are the use of SSRI medications, right? So selective serotonin reuptake inhibitors, which really have a phenomenal benefit in patients who have at least lifelong PE.
Yeah.
Lifelong PE is a neurochemical disorder. It's a serotonin disorder, and that's why SSRIs work.
Mhm.
Okay. So the literature will, if you look at it critically, improvement in latency time
Mhm.
from the time of penetration to the time of ejaculation. That's called latency time. And, 100 to 600% improvement in ejaculatory latency time. Now, it's not likely that that patient is going to go to 12 minutes, right? The guy comes in and says, 30 seconds, right? It's not likely they're going to go to 12 minutes. But we certainly see people go to 2 and 3 minutes. And, of course, in a relationship that's distressed because of this, that's a big benefit to this man. They're not drugs without side effects. The SSRIs that work best are probably the first generation, right? So the, Prozac, Zoloft, Paxil, so fluoxetine, sertraline, and paroxetine. I use fluoxetine because it's effective, but it also probably has lower side effects than some of the other SSRIs. The best drug around is clomipramine. Okay. Very clear from the literature. Clomipramine is an excellent drug with the highest side effect profile. So we just don't use it.
Yeah.
And that will be kind of an overview of the treatment. It is a not on demand. There's a lot of interest in, well, I just take it 4 hours before I'm going to have sex. They are receptor modulators. You need to modulate the receptor, and whether it's depression or PE, the SSRI needs to be on board for probably 2 to 4 weeks before it really is manifesting its greatest effect on the receptor. So it just doesn't make a lot of sense to that people are using these drugs on demand. The other group of drugs there's a lot of interest in for PE are PDE5 inhibitors. Right? So Viagra, Levitra, Cialis, and Stendra. And I think for the man with secondary PE, so acquired PE, secondary to ED, this makes perfect sense.
Yeah.
Okay. And that's the group of men in who we're going to work on your erections first.
Exactly.
And I'm going to tell you, you're going to see an improvement in your ejaculatory latency.
Yeah, absolutely. And the other one that I think is less often discussed is delayed ejaculation.
Yeah. Delayed orgasm is a really fascinating concept. So more than 90% of all causes of delayed ejaculation are related to one of 5 things, or a combination of those 5 things. One is SSRI use. So there are men who don't have premature ejaculation, who are on women who are on SSRIs for depression and anxiety, and they have such a prolongation in their ejaculatory latency time that they actually, some of them are anorgasmic. Okay, so we always explore: are you using an SSRI? Oh yes, I've been on an SSRI. How long have you been on it for? I've been on it for 20 years. How long have you had premature ejaculation? A year. So clearly that isn't the cause, right? So you want to look at the chronology of the use, the overlap between the SSRI use and the timing of the ejaculatory dysfunction. Number 2 will be low testosterone. Mauro Maggi, who's a world-famous endocrinologist from Florence, has some very interesting data that if you look at men who have delayed orgasm, that they're more likely to have low T or be in the lower third of the normal range. So we always check T in these men. Number 3 would be penile sensation loss. So the classic group there would be diabetics, for example. So they got a sensory neuropathy, glove and stocking. Remember, for clinicians, glove and stocking neuropathy, you always want to ask about penis because it's an extremity also, right? So diabetics. The other group at a cancer center are men who have neuropathy secondary chemotherapy. So our testis cancer patients who are treated with cisplatin, for example, some of them will end up with at least temporary glove and stocking and penile neuropathy. Mm-hmm. Number 4, we group into a group of conditions that we call hyperstimulation syndromes, which includes idiosyncratic masturbation, which we talked about a little bit before, but also men who have the death grip or who are 2 hours of masturbation at a sitting or 4 times a day. And the penis just becomes desensitized, right, to stimulation. And then number 5 is psychological, right? And I say to our trainees that psychological sexual dysfunctions, any psychological sexual dysfunction, is a diagnosis of exclusion. We first want to rule out the other organic causes. So our patients who come in are asked about SSRIs. They get a T level checked. We do penile vibratory sensation testing. That's called bioesthesiometry. In the office, there's a nomogram for that. We ask about masturbatory practices. And if all of those are normal, then generally I'm very comfortable saying to them, I believe this is psychologically related. Now, what's very interesting is if you ask men about their orgasmic capacity on their own versus with a partner, and they say, no, I'm fine on my own. It's just with my partner. There are only 2 causes of that: penile sensation loss and psychological. So bioesthesiometry will tell us very rapidly, right? And when I was in my first day in medical school, the professor of surgery came in and talked to us and said, you'll make 80% of your diagnosis by talking to people and examining them. And in sexual medicine, the more you talk to people, the more you find out over the course of your consultation. Now, my initial diagnosis in my mind of psychological sexual dysfunction, as you keep talking to them, it just becomes confirmatory in the vast majority of cases.
And I wanted to go back to the low testosterone. Does replacing the testosterone actually improve the delays?
Yeah. So that's an excellent question. So we're presupposing if somebody has low T and they've no other overt cause of delayed orgasm, that must be the cause. I'm going to tell you in our data, and this is not yet published, okay, manuscript in preparation. Only 1 in 4 of those men with low T who got delayed orgasm are improved. Their latency time is shortened by going on testosterone therapy into a physiologic range. And so I think that realistically speaking, most people with delayed orgasm have more than one factor. And I suspect just like ED, they've got an organic factor, let's say, but there's a psychological component.
Yeah.
Right. And so I'd say to patients, you have an orgasm, male or female, when you're in the zone. And when you're out of the zone, anything that distracts you is going to decrease your chance of having an orgasm. So, for example, I'm worried about getting hard. I'm worried about staying hard. I'm worried about, am I going to have an orgasm tonight? So one of the strategies we try employing in our patients, we try have them defocus on orgasm, explore intimacy with their partner, enjoy the encounter, put orgasm off, not worry about it. And some of those patients actually, when they defocus, they're able to have an orgasm because they're not, hyper focused on, am I going to have an orgasm? The other thing we ask men about, particularly older men, is you've got a definitely having an orgasm now. It started 2 years ago. 20 years ago, how long did it take you to have an orgasm? And how long was your encounter? My encounters usually last 10 minutes. How long are you lasting now? Well, I give up after 5 minutes, right? And so older men, because of stamina issues, strength and stamina issues, sometimes just don't participate in relations that are long enough to allow them to achieve an orgasm.
Mhm.
That's another kind of avenue of exploration that's worthwhile in the medical history.
Yeah, absolutely. I think that anyone who has sexual dysfunction has psychological components because it's stressful, right? Something's wrong with your genitals, something's wrong with your experience during sex, and you're stressed about it.
One of my favorite Mulhollisms is you're only as good as your last erection, right?
Yeah.
And so if your last erection doesn't live up to your expectation, and that doesn't have to be a hopeless erection, just isn't as good as you want it to be.
Mhm.
So some 25-year-olds want to be like 10 on a 10-point scale, and anything less than that's a problem.
Mhm.
But if that is happening to you, then you have anticipatory anxiety walking to the bedroom the next time. And of course, adrenaline is the world's most potent anti-erection chemical, right? So it causes the muscle to contract, and muscle in the penis, muscle relaxation causes erection, right? And so it opens the valve. And these are men who get, I get fully rigid and I go to penetrate and I lose my erection. They don't have venously. They don't have smooth muscle collagenization. They have adrenaline. And of course, the longer that goes on, the bigger the problem it is.
It is really truly a problem. And I think part of it is that men are not taught that their erections are going to fluctuate during the lifetime, and that some days you will not have as firm an erection as others. And so the second you have an erection that's less firm, you will stress.
Yeah, and not even over one's lifetime, over, from week to week.
Yeah, exactly.
We've got lots of finance people in Manhattan who are like incredible stress,
Yeah.
right? So any stressor in your life can have a negative effect in the bedroom because adrenaline is an anti-erection chemical.
And then penile sensitivity loss. With diabetics, you can try to improve glycemic control, but some of these are and nerves. And so are there techniques that you offer people with penile sensitivity loss?
Yeah, so first of all, from the chemotherapy standpoint, so let's say the cisplatin testis cancer patient treated with cisplatin, that's frequently temporary. It's not always, but it's frequently temporary. But for the diabetic, where it's an end organ damage and that's it, and glycemic control can help no deterioration of the sensation loss, but it's not necessarily going to improve the current sensation loss. We're big fans of penile vibratory stimulation. So we talk to all of our patients about the use of variable amplitudes penile vibrators. We do biosthesiometry. We see that the sensation is markedly reduced. And we talk to them about PBS. And and we also talk about how they integrate that into lovemaking, right? So there are many men, I haven't had an orgasm with my diabetics, with my partner in 10 years. And I just pull out and I masturbate or she masturbates me. Integrating a penile vibrator into self or partner-based relations is, I think, a very valuable tool. Enhances intimacy, enhances the participation of the partner in the orgasmic kind of event. So we're big fans of PBS.
I want to talk briefly about erectile dysfunction and specifically prevention. So I would argue that the biggest prevention is lifestyle, right?
Sure.
Avoiding comorbid conditions, diabetes, high blood pressure, high cholesterol. But let's talk about things like taking Tadalafil daily as a preventative measure.
Right. So first of all, what's good for your heart is good for your penis, right? Control your blood pressure, your cholesterol, your sugar, reduce stress. Exercise is an incredible endothelial protectant, right? So the lifestyle things, just as you said, Rena. Okay. There was a very famous cardiologist by the name of Graham Jackson coming up. And Graham Jackson was the most penis-friendly cardiologist in the world. He was actually a cardio-urologist. And when asked that question, he said, you want to go on the penis protection cocktail. And when asked, He says that's a PDE5 inhibitor, it's a statin, and it's an angiotensin receptor blocker, right? Now, that's a pretty heavy pharmacologic load, right?
Yeah.
I think your question about regular use of PDE5 inhibitors is just an absolutely fascinating one. So, in the general population, first of all, these drugs are potent endothelial protectants. So, if you want to look at science, you got the D'Souza paper on sildenafil, you got the Rosano paper on tadalafil, where men were given these medications nightly for a period of time, and then they were stopped. And using a thing called flow-mediated dilation or brachial artery reactivity, where you're looking at the vasodilatory effects of these drugs, of a compression on an artery, you saw preservation of endothelial function days after cessation of these drugs. So these drugs are potent endothelial protectants, and the penis is a big endothelial organ, right? And the endothelium is the master regulator of blood flow in the penis. So there is a solid rationale for using regular PDE5 inhibitors for the preservation of long-term erectile function. If you're in middle age, at least tadalafil and probably sildenafil also has some lower urinary tract symptom improving effects also. I want to talk about the Kloner paper, which got published in the Journal of Sexual Medicine about a year ago now. Bob Kloner is a very famous cardiologist in this country. And they did a database mining project looking at exposure of men who had ED without cardiac history, not necessarily without cardiovascular risk factors. And what they basically showed was looking at a huge number of parameters, cardiac-related deaths, MI, stroke, etc., is that those men who are using PDE5 inhibitors, the highest quartile of use, had a reduction in cardiovascular events, rates, and deaths. So these drugs, and it's incomprehensible to me and many people at my age and my seniority in the field, how Pfizer or Lilly never committed to doing an endothelial protection trial. Okay? I want to make one other comment about diabetics. So diabetics are among the most poorly responding patients to PDE5 inhibitors, them and radical pelvic surgery patients. And that's really related to their autonomic nerve function. Their nerves don't do well. The nerves supply nitric oxide. It's no nitric oxide. Viagra doesn't work.
Right.
Okay. So they do very poorly. So they come in and they have about a 40% chance of responding with a penetration hormone reaction to these pills. The 60% of men who come in who don't respond, I always say to them, I think you should stay on low-dose PDE5 inhibitors. Because one of the major means by which these patients die is, of course, cardiovascular events. And even before the Kloner data came out, I'm such a believer in PDE5 inhibitors and endothelial protection that I encourage our PDE5 inhibitor, non-responsive diabetics, stay on a PDE5 inhibitor. And nowadays, you can get generic sildenafil, 20 milligrams, for 20 cents.
You know? Get it so cheap.
Yeah.
Even tadalafil daily, you can get pretty cheap.
And if you use sildenafil, this is the D'Souza data, if you use sildenafil 25 milligrams for the study nightly for 14 days in a row, and then you stop it, and you do flow-mediated dilation 24 hours later, you get a day protection. So 20 milligrams, we say to our patients, is a 24-hour protective of your endothelium.
Is there any danger to being on long-term PDE5 inhibitors?
Not that we know of. You'd imagine 25 years into the experience that we would have enough exposure to our use in clinical practice that we would have seen some signals. There are concerns about two particular patient populations. One are malignant melanoma patients. There is some basic science, cell-based and animal-based work that melanocytes proliferation can be enhanced through PDE5 inhibitors. We don't really pay much attention to that in the patient with an excised melanoma that the margins are negative, they don't need adjuvant therapy. However, in our patients who do need re-excision, lymphadenectomy, node resection, lymph gland resection, or need adjuvant therapy, we do check with the primary oncologist first. And invariably they say, it's okay. We don't extrapolate from that basic science data to the human model. The other group of patients, which is really interesting, are the patients post-prostatectomy. Do regular use of PDE5 inhibitors increase biochemical recurrence rates? Do they increase the risk of cancer coming back? And I'm very happy to tell you now that we've just published a paper that shows very clearly at Memorial Sloan Kettering that it does not. And that's supported by Stacey Loeb's beautiful Swedish registry data, by Francesca Montorsi's data. So there's enough evidence now that I'm very comfortable telling people, clinicians and patients, that regular use of PDE5 inhibitors in the prostate cancer patient does not increase the risk of cancer coming back.
Well, thank God, because I feel like we give it to them at
I
once.
know. I know. In our rehab program, sure.
Yeah. I think in general, do you think that there's benefit for the young, healthy man to start a sildenafil daily or sildenafil daily?
That's an interesting. I asked that question of we had a cardiologist talking about this yesterday at one of
Mhm.
our conferences. I asked him that question. He was not he wasn't able to give me an age at which we should start. I would say if you're a healthy 40-year-old, you should consider start doing things to protect your long-term erectile function. Okay, if you're a sexual human being, and not everyone is, but if you're a sexual human being and your intercourse-based relations is important to you, then I think you need to start thinking about your penile health. Okay. We talked about the lifestyle things. But I think that if you were 40 years of age and you were interested in protecting your penis and you said, I'm going to take regular PD5 inhibitors, I would have no problem with that. I think if you said to me, the 25-year-old comes in who's perfectly healthy, my concern about that population is not so much that they're looking to protect their penis, but they're looking for an extra boost. And while there's no physical dependency on PD5 inhibitors, there's most certainly the potential for psychological dependency, right? This concept of, I'm great when I use vitamin. Guy with perfectly normal duplex operates on his vasculature is perfectly normal. And he's on PD5 inhibitors and he is only able to have penetration hardness when he's on the pill. Not because his machinery is not good enough, but because his confidence level is so low without the pill. So I think that's something that I'm just a little bit concerned about in the younger population.
Sometimes I find that the opposite is sometimes true. It allows them to get their confidence back. If they have a lot of anxiety around sex, that it becomes a little easier to have an erection, and then we try to wean them off. And that is sort of a challenge.
Yeah. So we published a paper. Lawrence Jenkins was the first author on this paper. He was one of my fellows. He's now at Tulane. And we published this a couple of years ago, and we showed that if you are a man with psychogenically needed ED, so normal hormones, normal vasculature, and the strategy you talked about, confidence restoration through PD5 inhibitor use, 90% of those men who are in a relationship are off pills in the long term, that you can restore their confidence. Now, I say in a relationship, because if you happen to be single and every 2 months you're starting a new dating or a new situationship, right? I think that that's a new stressor to you. Every new partner is a new adrenaline generator, right? So I think that in the confines of a sustained, loving, comfortable relationship, then people's confidence comes back.
Yeah.
In time.
I love that you know the word situationship.
Sexual medicine doctor.
Yeah. I want to briefly touch on intracavernosal injections, which are therapies that I think are very underutilized and underknown for men with erectile dysfunction. So let's talk about how they work.
Yeah.
And how many slots today?
Yeah, so that's a bit of a lesson in history, right? So credit one's still alive. I think Ron Virag is a vascular surgeon in Paris, and during an operation on the lower limb, they were injecting medicine to cause vasodilation of the arteries in the leg, and the injection went into the wrong artery, and the patient got an erection. And that was an injection with a drug called papaverine. And then around the same time, a chap named Giles Brindley from the UK was doing this with a drug called phenoxybenzone. And that was 1982. And then by 1985, injection therapy became a big deal in the United States. It's never been, there are FDA approved and non-FDA approved drugs. So it is basically the use of vasodilator drugs that are injected directly into the shaft of the penis, into the meat of the penis, using a diabetic needle, middle of the shaft, nowhere near the head, mosquito bite, Mr. Jones. Okay. And depending on the population that you're looking at, but it has an incredibly high success rate. I mean, if you come in to see us and you're post-prostatectomy and you're start injections within 6 months, 92% and then get penetration, hardness erections, I said that you'll get an erection we'll be proud of. Okay. And they're incredibly, incredibly potent, right? From a safety standpoint, of course, the only concern will be priapism, really. Okay, so the induction of an erection that a man cannot get rid of. Those 4 hours, call your doctor erections that you see on TV. And the chances of that happening in a well-organized, well-monitored program is very low. In our program, it's 0.2% of men who get a priapism, and it's probably maybe 5 times not getting a prolonged erection. 2 hours, but not getting to 4 hours. But incredibly, incredibly effective. The problem is that there's a 50% dropout rate over 5 years, right? And this is not even in the rehab population. This is in the general ED population. People just get tired of the whole injection process. It's not very spontaneous. Hold on, honey, let me inject. Okay. And so I talk with all of my patients and our trainees about the concept of integratability. That if you're on a drug treatment, on a treatment for ED, whether it's a drug, a vacuum device, even a mental health strategy or an implant, if it's not integratable into your lovemaking, you're never going to stick with it.
Yeah.
Right. And so the problem for injection therapy, as effective as it is, it's just as difficult to integrate into lovemaking. So take, for example, the 45-year-old recently divorced male, post-prostatectomy, out, wants to start dating again. He's single. Now he's got to bring his injection medicine on a date with him, right?
Mhm.
So it's hard to integrate that into lovemaking. We understand that. But I think for temporary confidence restoration, for showing men that their machinery is functional again, I think injection therapy is a fantastic strategy.
Are there errors that men make when starting therapy?
Yeah, I mean, the classic errors would be, and errors in quotations would be just bad injection technique. Even though we train them how to do it in the office, we use 2 injection visits. Many urologists use 1. We use 2. They're nervous at home and they just don't inject at the right angle, the wrong depth. We have men who are, it's needle in, plunger down, needle out, pressure between 2 fingers, Mr. Jones, for 3 minutes, right? But the plunger is going down, they're pulling the needle out because they got to get the needle out as quickly as possible. The major concerns we have are men who change the dose themselves, right? Okay, so we send patients home after the second injection visit. We say, you're on X number of units of Trimix or Bimix or Papaverine. We don't use a lot of Edex or Caberject, which are the 2 FDA-approved drugs. And they just, I'm not getting an erection that I'm happy with, and they self-adjust their dose. And they'll come into me all the time, and they'll say, well, I just went from 4 to 5 units. And I'll say, well, Mr. Jones, that was a 25% increase in your dose. So if we look at our patients who don't do what they're told to do, they have a 10-fold increase in their priapism rate.
Yeah.
Okay. So that's an issue. Then we have men who want to inject twice within the same day or twice within 8 hours of each other, which is, generally speaking, no. But if you're well trained and well monitored, it's really easy to do. It's actually quite difficult not to do it properly.
Yeah. I think the other thing about the medications is some of the medications require refrigeration.
Yeah.
And that can be a real challenge.
Yeah. So medications that contain prostaglandin E1, because it is inherently unstable and loses its potency, its kind of activity over a 4+ month period, that needs to be refrigerated for sure. Now that's over time. So if you've got a bottle of Trimix, you want to refrigerate that. You don't want to be carrying your bottle around wherever you're going.
Yeah.
But if you're going away for a romantic weekend and you're on injection therapy, just pre-fill 2 injection syringes.
Yeah.
And you don't have to be crazy about refrigerating them. Your prostaglandin doesn't deactivate over the weekend. It's the accumulated exposure over time, weeks or months, to room temperature that causes a problem. But for those patients who struggle with refrigeration, then we just use Bimix, Papaverine, and Phentolamine without prostaglandin.
So I know you have a lot of expertise from working at Memorial Sloan Kettering on particularly taking care of men after prostate cancer who have erectile dysfunction. So what is the true rate in modern day of erectile dysfunction after a radical prostatectomy?
Yeah. So I think that's an excellent question. And it's difficult to answer it with a number because, as you know very well, there are many confounders, right? So patient age is a factor. The younger the patient age, the better men preserve their function. There is based on erectile function. Okay. Sometimes age is a surrogate for that, but sometimes the younger men have got bad erections due to diabetes, for example. So the better your erectile function going into surgery, going into radiation, the better your recovery or preservation. At the time of surgery, there is nerve sparing, and that's very, very important. So for somebody who comes in to see me pre-op, I always say when you speak to your surgeon the morning of surgery in the pre-op area, don't say, Dr. Easton, chair of urology at Memorial Sloan Kettering Cancer Center, Dr. Easton, don't forget, do your best with my nerves. The better the nerve sparing, the better the recovery. And then from a radiation standpoint, the higher the radiation dose, the greater the problem. And then probably the most penis-threatening thing that you can do to a human being will be take their testosterone away from them. And as important as androgen deprivation therapy, ADT, those drugs that cause testosterone to go to zero, as important as they are in the radiation patient and in the advanced prostate cancer and metastatic prostate cancer patient, they are really, really bad for erectile tissue. So if you think of your penis like your biceps, Mr. Jones, you put your hand around your penis, most of what's inside your hand is a muscle. If you put your arm in a plastic cast for a year, that's really what Lupon's going to do. Those drugs, Lupon, abiraterone, etc. That's what those drugs do to your penis. You need some testosterone for erectile tissue health. It's actually probably not a huge amount of testosterone, but you need some. When you have none, reflexly, in time, that muscle undergoes collagen deposition. Now, that's not in 3 or 4 months, but those patients who are on hormone therapy for a year and a half, 2 years, which is increasing now because of the stage migration of prostate cancer, those patients have really huge problems. So if you take men in our practice who have been on long-term hormone therapy, almost none of them will ever be PD5 inhibitor responders. They will need at least the injection. So getting back to your question, after prostatectomy, I think it would be very fair to say to a patient, in general terms, you will have a 50 to 60% chance of getting back function with or without a PD5 inhibitor 2 years after your prostatectomy. And I think those figures are approximately the same for patients who have radiation therapy. Okay. Now, if you have radiation therapy with long-term ADT, if you have non-nerve sparing surgery, then these figures change dramatically. But I think to the average patient, 50 to 60%, PD5 inhibitor response rate 2 years is a very honest and reasonable estimate preoperatively.
And it's pretty much equivalent between surgery and radiation.
Yeah, I get these patients all the time. What should I do? And I always say, I'm not a cancer doctor. I'm not going to tell you what to do. What I say to them is as follows. 3 years after each intervention, the ED rates are approximately the same, provided you've good nerve-sparing surgery and you've radiation therapy as monotherapy. When you start doing non-nerve-sparing surgery, when you start doing ADT of different durations, then it just becomes impossible to estimate for those patients.
Yes.
So I say to the patients, speak to your surgeon about nerve-sparing, based on your PSA, your MRI, etc. What are the chances of good nerve-sparing? And I say to the patients, speak to your radiation oncologist and ask about the role of ADT, and especially about the duration of ADT. And I always say the same thing to patients, ask your rad-onc, your radiation oncologist, about the survival benefit of 2 versus 1 year versus 6 months. And you decide then, is that survival benefit important to you?
Yeah.
If it's 6 months or 6 years, you make that decision. I don't think I have a phrase that I use now in my lectures of obsessive oncocentricity. That cancer doctors are like, PSA for prostate cancer or CEA for colon cancer, etc. And really, we need to empower patients to make better decisions for themselves, right? So I'm a big patient advocacy. This is classic shared decision. The patient should be the one who's making those decisions. We give them the information and then they decide.
Absolutely. Because quality of life matters.
Yes. We are survivorship physicians, right?
What about more focused therapies? Like there are now emerging focused therapies, high intensity frequency ultrasound, also called HIFU, cryotherapy, those sorts of things.
Yeah.
What have you seen in those patients?
Yeah. So there really are no long-term studies to look at cryotherapy, HIFU, and some of the more modern things like irreversible electroporation and things like that have had as a focus sexual health. Okay. I think that if you look at Mark Emberton's data from the UK, that unilobar treatment, so hemigland ablation it will be called, so half of those patients are most probably going to do better from an erectile function standpoint than classic radical prostatectomy or radiation patients. I think, however, when you get to whole gland ablation, then you start getting into rates of ED that are approximately similar. Okay. To prostatectomy. We have a lot of patients at Memorial who want kind of ejaculation-sparing prostate cancer treatments. And so they go for things like HIFU or they go for things like IRE. Okay. They have to be made aware of this. If they're listening to this, you must understand that those treatments are administered very closely to the ejaculatory ducts. And the ejaculatory ducts are millimeters apart from each other. Right? And so, I'm only having hemigland ablation, but if they're treating around the area of the right ejaculatory duct, there's a chance your left ejaculatory duct is going to get injured. So it's not uncommon for those men to come in and at least temporarily for them to have an inability to have ejaculation after those minimally invasive procedures. That leads me to the idea of ejaculatory distress, which is a really interesting concept about men who are distressed post-prostatectomy, for example, at their inability to ejaculate. About a third of our straight men are very bothered. Now, that's 80+% of gay men, right? But about a third of our straight men are bothered by the fact that post-prostatectomy, I'll never ejaculate again. And that's not something that's well appreciated by surgeons.
Yes, it's not discussed to a great extent prior to any procedure, whether that's surgery or radiation.
Yeah. Yeah. And by the way, after radiation, if you look at our data, and it's the data that we published, 50% of men at 3 years and 90% of men at 5 years no longer ejaculate. Just the radiation damage to the prostate, the occlusion of the ejaculatory ducts, they just stop ejaculating. So in time, they also stop ejaculating.
Now, I want to clarify ejaculation versus orgasm.
Yeah.
Because what happens to orgasmic function after these therapies?
Yeah. So after prostate, first of all, let's get radiation out of the way because there's really not much literature out there. Okay. So my anecdotal experience in a radiation patients, they tend to have better preservation of orgasm than the prostatectomy population. If you look at prostatectomy patients, while they don't ejaculate, nearly all of them are going to be orgasmic. And this is a classic thing in our practice, as you know, where men just don't understand. That's the difference between ejaculation and orgasm. Ejaculation is the expulsion of semen, and orgasm is the pleasure that's derived from that. Yes, our blood pressure goes up. Yes, our pulse goes up. Yes, there are pelvic muscle floor contractions during orgasm, but the pleasure is a cerebral phenomenon. Okay, so men are orgasmic after prostatectomy. Everyone says the same thing. It feels different. Right? And even in the long term, I think you would have to, we talk about the new sex after radical prostatectomy. Part of that new sex is you have to accept that your orgasm is going to be different in some way. However, if you look at orgasmic intensity at 2 years, about 50% of men will say their orgasmic intensity is less. About 40% will say it's about the same. And 10% will say consistent. It's more intense post-prostatectomy. And we've no idea why that is. Right?
You mean it's the pelvic floor?
It has to be something to do with pelvic floor.
Yeah, I mean, do you think it's like in those 10%, their pelvic floor strength considering Kegel exercises to prevent leakage? And
that's never been looked at. That's an interesting idea. We've been very interested in doing urethral pressure profiles and urodynamic parameter in these patients. I don't know the answer to that, but it is not a fluke. It is I've been in practice 28 years, and over my 28 years, thousands of post-prostatectomy, it is 10% of men who have increased orgasmic intensity. There was a lot of concern that, the semen bolus going through the urethra was important for orgasmic intensity, but the 10% having higher intensity says that can't be the case.
Well, I think it's also mental there, right?
Yeah.
Because it's so ingrained in that component of pleasure, reaching that climax, that feeling that, and when it's reduced or gone, it can feel like less intense.
Yeah, and I think that links to the whole, ejaculatory orgasmic distress that occurs after radical prostatectomy.
What about, I think many people don't talk about this, climacturia. So meaning leaking urine during an orgasm.
Yeah, so orgasm-associated incontinence. So the umbrella term is sexual incontinence, right? So sexual incontinence is two things. One is climacturia and the other is arousal incontinence. Climacturia occurs in at least 60% of men on one occasion after prostatectomy. It's very, very common. So we say to our patients, in those first half dozen orgasms after surgery, avoid oral sex, towel on the bed, or self-stimulation, or sex in the shower, right? If you're going to have climacturia, almost certainly it's going to happen in those first half dozen orgasms, right? It can be drops or it can be ounces, as you know. And there are some men who like the concept. In the gay male population, the GBM population, those men are sometimes not turned off by the fact that they ejaculate, they squirt urine. Mm-hmm. This is a bladder neck or urethral length phenomenon, right? So normally at the time of orgasm, the bladder contracts, the floor contracts, the bladder neck contracts, and the bladder contracts. So when that bladder neck is incompetent early after surgery, then it's not contracting completely and urine leaks out, okay? Now, you're not going to expose your partner, male or female, to increased risk of STIs or UTIs or anything like that. It becomes an aesthetic issue, to be honest with you. 20% of our patients, that's a third of that 60%, have that problem consistently throughout the first year. Less common in the second year, generally rare in the third year. If it's early on and it's very bothersome, then we use one of these variable tension loops. So a loop that you can put on your penis that you can cinch down. It's not fixed like a constriction band. And you don't need a lot of tension on that. What you do need is a good backboard. So you need good rigidity of the penis. Because if you don't have a good erection, then you're not going to get that compression of the urethra. Fortunately, with injection therapy, most of our patients in our rehab program are doing very well early on. So they have a good backboard. But that's a very useful tool. And for most men, really gets rid of the leak, the climacturia early on. And then, as we've already talked about, it goes away most often. Arousal incontinence is more problematic. So arousal incontinence are men who are just, it's also called foreplay incontinence. They're just getting touched by their partner, getting a back massage, having sexual thoughts, and they start leaking urine. That's a sphincteric issue, not bladder. That's a sphincteric issue. And so that is more closely aligned with diurnal incontinence. So men who leak and they wear pads in the early stages after surgery, that's more, arousal incontinence is more linked to that. That's much more problematic in the sense that it's not predictable, right? Or climacturia occurs at orgasm. Easy, right? So I know I need to put my band on and then I'm fine, right? Arousal incontinence is much more distressing because it just happens. And guys can be in a restaurant and they start leaking urine. Remember, I say to patients that the three things that are worse in your continence are fatigue, not you being tired, your pelvic floor muscle being tired. So at the end of the day, alcohol intake, right? And then sexual arousal. Okay, so that's a much more problematic problem and more distress. For the patient with climacturia, that is long term and is clearly not going to go away. Then, of course, we have sling procedures, and they tend. I don't do those, but they see our kind of your avoiding dysfunction group at Memorial, and they kind of put slings in.
What is your rehabilitation procedure for men after prostate?
So first of all,
I think prostate cancer surgery.
Yeah. So
treatment.
Yeah, so let's deal with the surgery group first. So we love to see patients prior to treatment, right? So we love to see a prostatectomy patient scheduled for prostate surgery next month coming in, and we'll do prehabilitation. We'll do that for 2 weeks beforehand. And that really centers around the concept of endothelial preconditioning. We talked earlier on about PD5 inhibitors being endothelial protectants. So if you can upregulate the endothelium before it gets injured, and nerve damage causes endothelial problems, then you're kind of ahead of the game. So we like to start that, and that's regular use of PD5 inhibitors for the 2 weeks prior to surgery. So that can be 5 milligrams of Cialis daily, tadalafil daily, or it can be 20 milligrams or 25 milligrams of sildenafil. We don't use a lot of Levitra. It also ran to sildenafil, and we don't use a lot of Stendra, except in people who got terrible side effects with the other PD5 inhibitors. It does have the low side effect profile, the poorest kind of insurance coverage, and the most expensive PD5 inhibitor. Post-surgery, if you see us pre-op, we're going to say 2 weeks before, 2 weeks after surgery, low-dose PD5 inhibitors. Even with the catheter in place, Dr. Mull, even with the catheter in place. And we really try to communicate. This is not to give you an erection. This is to protect the tissue on the inside of your penis, right? And then we say to them, 3 weeks, starting at 3 weeks after surgery, 3 weeks 3, 4, 5, and 6, I want you to start trying to get an erection, right? And then let's say you're on daily tadalafil, 5 milligrams a day, 2 weeks before, 2 weeks after. You continue your 5 milligrams a day, and then you take a booster dose. 5 or 10 milligram booster on top of that. That booster should be taken at least 4 hours before sex because the Cmax is at 2 to 4 hours. But the booster is good for 24 hours, Mr. Jones. And that's how we would use Cialis. With Viagra, you just you take nightly Viagra, and the day you're going to take the 100 milligrams, you'll skip the nightly dose. And when I see them 6 weeks after surgery, hopefully they'll have had 2, 3, or 4 attempts at answering the question, are they a PD5 inhibitor responder or not?
Okay.
The next piece of information is really important for those people who are listening to this. 15% of men are a PD5 inhibitor responder 6 to 12 weeks after surgery. 1 in 7 men are a PD5 inhibitor responder. So your expectation before surgery should be, it's a bonus if I respond. The likelihood is I'm not going to respond. And people say, well, Dr. Easton told me my nerves were perfectly preserved. Yes. Maneuvers were used by the surgeon to protect those nerves. Those maneuvers cause your nerve to go to sleep. Okay? Those nerves go to sleep for 9 to 12 months. It takes another 9 to 12 months for them to wake up fully. That's why erectile functional recovery is 18 to 24 months. When they come in to see me 6 weeks after surgery, if they're a PD5 inhibitor responder, fantastic. Now I want you getting 2 erections a week at least. Okay? What we're really trying to do is we're trying to replicate nighttime erections, right? That blood flow, oxygen, and stretch of the muscle. Okay? If they're in the 85% of men who do not respond to PD5 inhibitors, straight to injection therapy. Well, what about give me another couple of months before we make a decision on injections, Dr. Mulhall? You're not going to respond. You don't respond in the first month to a PD5 inhibitor. The low point in erectile function is 4 months after surgery, right? So those PD5 inhibitors, responders, they don't need injections initially, but they're told you have a 25-40% chance of a drop by the 4th month, right? But the PD5 inhibitor non-responders straight to injections. And our goal is to get all men off injections back onto pills by 24 months after surgery. Radiation is a little bit different. We do like to start before, and we keep people on low-dose PD5 inhibitors for the first 2 years after surgery, after radiation therapy finishes, or until their testosterone level normalizes. if ADT was used in those patients. And then we just say we weren't getting erections. And early after radiation, most men are just fine. There's a honeymoon period of about 12 months where their erectile function is not, in any way affected unless they're on ADT. So the radiation therapy monotherapy patients, just it's low dose PD5 inhibitors. If they're not able to get erections, then it's a booster dose or a maximum dose if it's sildenafil. If pills are not working, then it's injection therapy.
Do you use vacuums?
I don't use vacuum devices. There's good literature. Toby Kohler and Bruce Dawkin have 2 independent studies looking at vacuum device as a preserver of penile length. Okay. But I'm a big fan of the concept of cavernosal oxygenation. And vacuum devices don't oxygenate the penis. So our vacuum device utilization is very low, and it's for patients who are needle phobic and won't do injection therapy. And by the way, there are 2 papers, the Cialis React trial and Memorial Sloan Kettering data. Bobby Barucham is the first author in that paper, which shows that regular PD5 inhibitor users, that's a penile-like preservation strategy also, because it combats that muscle atrophy, which is really collagenization, but it combats the atrophy. So we're not big vacuum device users. If they want to use it on top of pills and injections, that's fine. Now you got like seriously multimodal therapy. And the compliance with that is very low.
Is there something on the horizon that you think is really exciting for men who have gone through prostate cancer treatment?
Yeah. So the first thing will be in the prostatectomy and radiation group, modulation of vascular risk factors prior to therapy. So we are very, very hot now on obstructive sleep apnea, very low testosterone levels, and diabetes. And if you can have a man who's got a Gleason 3+4, high volume cancer, needs a prostatectomy, not a candidate for active surveillance, is it possible to postpone his surgery for 3 months and work on his OSA treatment, get him on CPAP or use Inspire or whatever it would be, modulate his glycemic control, change his testosterone, right? Testosterone is a neuromodulator, right? So if you've low T and you have a prostatectomy, your nerves don't recover as well. So that's the first concept. So modulation of host factors in an effort to optimize endothelial function long term. The second thing that's really, really interesting, and there's animal research going on at the moment, is the concept of nanotechnology, where hydrogels might be applied to the nerves at the end of the operation. And in that hydrogel, you would have different times and durations of elution, the medication coming out of the gel. Things like antifibrotic agents, anti-apoptotic agents, pro-neuromodulatory agents that could start, the anti-inflammatory would start immediately and the antifibrotic a bit later, and then the pro-neuromodulatory. They just get eluted over different time periods. That to me is an absolutely fascinating concept. I think the idea of systemic neuromodulators, there are 2 large trials that have been done, neither of which showed benefit. So I don't think that the systemic approach is going to be, I think it's going to be locally applied neuromodulator. And then the final thing, of course, is, the $1 million question is going to be restorative therapies. Low intensity shockwave therapy, PRP, stromal vascular fracture injection. We just don't have data yet to answer those questions. Even in the general ED population, most of the studies are very small. The randomized controlled trial studies are short, very small numbers of patients, not good characterization of the patient population. So we have patients come in to see us and say, well, should I do shockwave therapy? And I'll say, listen, there's 2 concerns. One is the cost, all right? And number 2 is those restorative therapies, which have induced growth factors, have never been studied specifically in a cancer population. So until we have good safety data, I think I discourage patients from doing that, the prostate cancer patients. And I think everything I've just said pertains to radiation patients also.
Absolutely. So we share a few questions at the end of our podcast for everybody, and it can be related to your field or not.
Mm-hmm.
What's something you know now in life that you wish you knew earlier?
There's a lot of papers on my CV, and there's almost 400 papers on my CV. And the question I'm asking myself now at 62 years of age is, if I'd settle for 300 as opposed to 400, would I be happier now? I think if you take people at the upper echelons in any field of medicine, committed academicians, contributing to the field, leaving a legacy, I think they've all made sacrifices. I think we can do 3 things in our life. And I say this to my fellows. I think you can make money. I think you can do the things you love, including spending time with your family. Or you can be an absolute world authority. And you can only do 2 of those things at the same time. And if being a world authority is not on your agenda in the first 5 years of your practice, you probably won't be,
Yeah.
right? And I think, the younger population are far more focused on work-life balance, and they're probably right than I was. And I know I made incredible sacrifices of mine, with my children, my family, things that I could be doing. So that would be one of the things that I would say in retrospect.
Is there a health hack or life hack you would share with our audience?
I'm just, I have friends who call me Vigorectic. I'm an exercise fanatic. I was an elite rugby player when I was in Ireland, and I've carried over that love for fitness all my life. And it is my meditation. And it just happens to be good for your penis.
Great.
Yeah.
This is good. If tomorrow you woke up and you couldn't be your oldest anymore, what would you be?
I would be a poet.
Really?
Yeah. I'm for many, many years, I've been obsessed by reading poetry, and I write a little bit of poetry bad poetry in my spare time. But I think I'm, me, and I'm a wordsmith.
Mm-hmm.
It's good to be a journal editor, be a wordsmith if you're a journal editor. But I love words, and the beauty of poetry is that you can use words in really any way you want.
Very artistic.
Yeah, and I just love the structure and the metaphoric nature of the poets that I love.
Who's your favorite?
Oh, I think Billy Collins, of course, ex-poet laureate in the States 2 times is one of my favorites. But my favorite poet's probably Simon Armitage, who's a very renowned English poet. He's a poet laureate from the UK. He writes remarkable poetry. And as an Irish person, of course, how could I not love Seamus Heaney, Patrick Kavanagh, Evan Boland?
Thank you so much.
My pleasure.
Please tell our audience where they can find you.
Yeah, I work at Memorial Sloan Kettering Cancer Center. My Twitter account is Save Your Sex Life, which is probably the best way to find me. And yes, and my delight to be here. And I very appreciative that the general population gets a lot of their sex education through podcasts like this. So thank you for what you do.
Thank you so much.
All right, my pleasure.
Thank you guys so much for listening to this conversation. If you guys are enjoying this content, do me one favor. Leave me a rating or review for the podcast on Apple or Spotify podcasts. This helps our podcast reach more and more individuals so that we can get a bigger audience and share all this evidence-based content to a larger number of people around the world. And as always, remember to take care of yourself because you're worth it.